Welcome to the lecture on transfusion in the neonate, thresholds and avoidance strategies. In this lecture, I shall cover the clinical indications for red blood cell transfusion in the neonates and the available evidence for transfusion in this patient population. Thresholds for transfusion will be suggested and strategies for avoiding transfusion explored. I shall also cover the use of other blood components in this group of patients. A list of references is included at the end of the lecture. When considering transfusion of red blood cells and other blood components in any patient, there are some general principles to be applied. Transfusion can be life-saving, but is not without risk, and these risks are covered in more detail elsewhere. They include blood-borne viral infections and transfusion-associated circulatory overload. In the preterm neonate, there are specific risks, including bacterial sepsis associated with intravenous cannulation and the postulated phenomenon of transfusion-associated necrotizing enterocolitis, which will be covered later in this lecture. The aim should be to keep administration of blood components to a minimum, to use them in the context of a guideline, and to follow good clinical practice, including communication and documentation. Current practice in neonatal transfusion is guided by the Transfusion Guideline for Neonates and Older Children, published in 2004 with amendments in 2005 and 2007 by the British Committee for Standards in Haematology. This established a lack of evidence base for neonatal transfusion, and furthermore, the UK Serious Hazard of Transfusion Reporting System has demonstrated that the neonatal population are overrepresented. A recent national comparative audit of the use of red blood cells in neonates and children in 2010 gave insights into current practice, including indications for the transfusion with red blood cells in over 1,000 neonatal patients. By far the commonest cause was anemia, 60% of which were symptomatic and 21% asymptomatic. The next most common cause was bleeding, followed by exchange transfusion for hemolytic disease of the newborn and anemia due to other reasons such as sickle cell disease. Other causes included sepsis, pre- and post-operative blood counts, respiratory distress, and sampling. The audit also identified room for improvement in practice, in particular with regard to a reduction in the use of late transfusions. Again, a fuller account of causes of neonatal anemia is covered elsewhere, but it is pertinent to mention anemia of prematurity here. Anemia in the postnatal period is a normal phenomenon, in part due to the reduced lifespan of fetal red blood cells, and in the preterm infant, erythropoiesis is inefficient as erythropoietin levels are low. The additional effect of high phlebotomy losses in this group of sick neonates further exacerbates the problem, as frequent sampling can lead to a significant loss of volume as a proportion of the total circulating blood volume. The effects of anemia of prematurity include the immediate impact on oxygen delivery and longer-term concerns with regard to impaired growth and development. The evidence for transfusion of red blood cells in the neonate in terms of thresholds is not robust. Experience tells us that babies in intensive care with significant lung disease and high oxygen requirements do not tolerate anemia, as oxygen delivery is impaired. Treatment should be aimed at optimizing oxygen delivery, and this may include red blood cell transfusion to raise the hematocrit and improve systemic blood pressure. The desired hemoglobin will depend on the clinical condition of the patient, and as the level of dependency falls, so can the threshold for transfusion. There are a number of clinical studies, some of which have been included in a Cochrane review, looking at suitable thresholds. The Cochrane review by White and Kaplani in 2011 compared 4 trials which included over 600 infants, comparing low and high haemoglobin thresholds. The authors concluded that the use of restricted thresholds resulted in a modest reduction in exposure to transfusions and did not have a significant impact on death or major morbidities at discharge or follow-up. They cautioned against a further reduction in the lower limits and were of the view that longer-term follow-up was indicated. They also advised against raising the hematocrit unnecessarily. As previously indicated, a concern related to transfusion of the preterm neonate include the risk of developing transfusion-associated necrotizing enterocolitis, and 3 recent papers have looked at this. Paul et al. Found an increased odds of necrotizing enterocolitis after transfusion of red blood cells in premature infants, but causality could not be established. Blau et al. Concluded that packed red blood cells related necrotizing enterocolitis exists and is characterized by a severe neonatal gastrointestinal reaction after transfusion of packed red blood cells for anemia. Stritzka et al. Found that exposure to transfusion in the previous 2 days was an independent risk factor for necrotizing enterocolitis. What was clear was that the more preterm and low birth weight an infant was, then the greater the risk they were of transfusion-associated necrotizing enterocolitis. Given the concerns surrounding the use of blood components in neonatal patients, it makes sense to take steps to avoid or minimize transfusion wherever possible. A number of strategies have been proposed and some evaluated scientifically, and others are common sense. Delayed cord clamping and minimizing phlebotomy losses are the mainstay of these strategies. Routine use of antenatal and postnatal anti-D for rhesus-negative mothers has reduced the need for exchange transfusion for hemolytic disease of the newborn, and early postnatal immunoglobulin for the babies has been shown to avoid exchange transfusion, although it's worth remembering that this too is a blood component. Given the role of low erythropoietin levels in preterm babies and the contribution to anemia of prematurity, it would seem logical to treat this group of patients with erythropoietin. However, as I shall come to shortly, this is not without concerns, in particular with the development of retinopathy of prematurity. The Cochrane review by Rabe et al. Concluded that delayed cord clamping from between 30 seconds and 120 seconds conferred benefit on a number of parameters in preterm infants without adverse effects. These included fewer red blood cell transfusions and a reduction in the incidence of intraventricular hemorrhage. The caveat being that it would be difficult to support delayed cord clamping in infants who required resuscitation. It is unlikely that phlebotomy losses can be avoided altogether in the neonatal patient, particularly those requiring intensive care. However, by adhering to strict minimal testing practices and using microsamples for near-patient testing and monitoring, for instance, hematocrit and serum biochemistry, such as electrolytes and bilirubin levels, sample volumes can be kept to a minimum. Given that low levels of erythropoietin leading to inefficient erythropoiesis is a contributing factor to anemia of prematurity, a logical therapeutic intervention would be to treat at-risk preterm neonates with erythropoietin. There are 3 Cochrane reviews relating to this subject. Early erythropoietin use, less than 8 days, has been shown to reduce red blood cell transfusion episodes and the total volume of red blood cells transfused. But a significant increase in stage 3 or above retinopathy of prematurity is a cause of concern. Late use of erythropoietin between 8 and 28 days has also been shown to reduce transfusion episodes and total volume of red blood cells transfused, but the effects were of a marginal benefit and there was no effect on additional outcome measures. When early and late erythropoietin use were compared, the early use of erythropoietin did not confer substantial benefit, one of the reasons being it did not prevent early transfusion prior to study entry. And given the concerns with regard to increased incidence of retinopathy of prematurity, erythropoietin for prevention of anemia of prematurity has not been adopted into routine use. The authors of these 3 Cochrane reviews have recommended directing research into the use of transfusion early in the neonatal course. Transfusion thresholds in the neonate depend on a number of factors which need to be taken into consideration. These include gestation and size, the age of the baby, and most importantly, the clinical condition of the patient, such as respiratory support and oxygen requirements, and the presence or absence of sepsis. Taking into account the British Committee Standards in Haematology document guidance, the outcome from the red blood cell audit and clinical studies, the following are suggested thresholds for transfusion of red blood cells in the neonate. Any patient with anemia in the first 24 hours of life or receiving intensive care, 120 grams per litre. Those with chronic oxygen dependency, 100 grams per litre. And late anemia in a stable patient, 70 grams per litre. The volume to be transfused can be calculated using the following formula: subtracting the actual haemoglobin from the desired haemoglobin, taking that value and multiplying it by the weight and then 0.3. A maximum of 20 mils per kilo should be administered to avoid transfusion-associated circulatory overload, and the prescription should be in millilitres. I shall now move on to speak about other blood components. Guidance for their use comes from the document from the British Committee for Standards in Haematology. With regard to platelets for term infants, 50 mils over 30 minutes. Preterm infants, 15 mils per kilo over 30 minutes. Fresh frozen plasma, 15 mils per kilogram over 30 minutes. And cryoprecipitate, 5 mils per kilo over 30 minutes. We'll now go on to talk about indications for their use, which is less clear. Thrombocytopenia is common in the neonatal intensive care setting and can be defined as a platelet count below 150 times 10 to the 9 per litre. A comprehensive review of the etiology of thrombocytopenia in neonates is out with the scope of this lecture, but broadly speaking, it is due to either an increased consumption or reduced production of platelets. In term infants, the main causes are maternal idiopathic thrombocytopenia, where the maternal platelet count will also be low, and neonatal alloimmune thrombocytopenia, where the maternal platelet count will be normal. The former has a milder effect on the newborn and may resolve without the need for platelet transfusion. Newborns with NAIT or NATE, however, are at risk of intracranial hemorrhage, so transfusion with human antigen-compatible platelets is indicated and may need to be repeated. Again, the platelet count will normalise with time. In the preterm patient population, early thrombocytopenia is likely to be due to antenatal factors, whereas late thrombocytopenia after 72 hours is more likely to be acquired and may be due to sepsis and necrotizing enterocolitis. Sepsis can, of course, also contribute to thrombocytopenia in term infants. Thresholds for platelet transfusion are derived by consensus rather than evidence base. It is clear that in a thrombocytopenic patient who is bleeding that a platelet transfusion is indicated. What is less clear is what should occur in a stable patient, and it is likely that platelet transfusion is unnecessary where the platelet count is greater than 50 times 10 to the 9 per litre. What is less clear is the safe lower limit if the patient is stable, and future research into this area is urgently needed. Platelets for neonatal transfusion Study 2, or Planet 2, is an ongoing randomised controlled trial to compare two different platelet count thresholds for prophylactic platelet transfusion to treat preterm neonates. In addition, the use of thrombopoietin mimetics, alluded to in a review article by Salmon et al., is an interesting area of future research. If both platelets and red blood cells are to be administered, then platelets should be administered first to avoid inline clumping, and it's also quicker. The use of fresh frozen plasma is indicated for a significant coagulopathy, as indicated by a prolonged prothrombin time, PT, or activated partial thromboplastin time, APTT. It's worth noting that clotting times in neonates are longer than in older children and adults, particularly in the preterm group of patients due to liver immaturity, and an APTT of up to 75 seconds can be normal. The coagulation should be rechecked following the administration of FFP. Cryoprecipitate is indicated for disseminated intravascular coagulation, where the fibrinogen level is low, below 1 gram per litre. This can be given with FFP, and it's important to correct the underlying cause and monitor the response to treatment. If platelets, FFP and cryoprecipitate are all to be given, they should be given in that order, as platelet concentrate will contain plasma and some clotting factors. I shall now go on to talk about good practice guidelines. The first thing to consider is communication. Parents should be informed, and the information given can be reinforced by a parent information leaflet available from transfusion services. Communication between clinicians and blood bank is also important, particularly between clinicians at handover times. Documentation is essential. Firstly, the indication for the transfusion, including clinical and laboratory values, the administration of blood component itself, and then the response to transfusion, both clinical condition and laboratory values. There are some safety aspects to be considered, particularly avoidance of out of hours for routine top-up transfusions. The total volume for transfusion should be prescribed in millilitres, and the process of the blood leaving the cold store to completing the transfusion should occur within 4 hours. In summary then, when considering transfusion of the newborn baby, the risks and benefits of red cell transfusion need to be weighed up and balanced. The aim being to minimise transfusion episodes whilst remembering that transfusion can be life-saving and improve outcome. Authorisation of blood components should be within the context of a guideline, and good clinical practice follows. Finally, a list of references referred to in this lecture are listed here. Thank you for listening.